is COPD diagnosed?
A clinical diagnosis of COPD should be considered in any patient who has dyspnea, chronic cough, or sputum production, and history of exposure to risk factors for the disease. Consider COPD and perform spirometry if any of these indicators are present in an individual over the age of 40. These indicators are not diagnostic themselves, but the presence of multiple key indicators increases the probability of a diagnosis of COPD. Spirometry is required to establish a diagnosis of COPD. Some key indicators are dyspnea that is progressive, which means that it worsens over time, characteristically worse with exercise, and persistent. A chronic cough that may be intermittent and may be unproductive. Chronic sputum production, any pattern of chronic sputum production may indicate COPD. History of exposure to risk factors like tobacco smoke, including popular local preparations, smoke from home cooking and heating fuels, and occupational dust and chemicals, and a family history of COPD. Spirometry is required to make a clinical diagnosis of COPD. The presence of a post-bronchodilator FEV1 to FEVC of less than 70% confirms the presence of persistent airflow limitation and thus of COPD. All healthcare workers who care for COPD patients should have access to spirometry. Appendix 1, Spirometry for Diagnosis of Airflow Limitation in COPD, summarizes the lung function measurements that are key to making spirometry diagnosis and details some of the factors needed to achieve accurate test results. Do you remember Mrs. Tubbs' post-bronchodilator FEV1?
No, there's just so much stuff. I'm so overwhelmed, Emily. I don't know how you remember so much. You are amazing.
I totally understand. I had to study really hard in Ball State's respiratory program. I hated learning about PFTs, but once I got a job and started seeing spirometry values every day, that made a lot more sense. You'll see.
Thank you so much for being so positive and understanding, Emily. My father had that test done, and can you explain why it's such an important tool for those with COPD?
Spirometry is required to make a clinical diagnosis of COPD and should be available to all healthcare professionals who work with COPD patients. Spirometry is a simple test to measure the amount of air a person can breathe out and the amount of time taken to do so.
How is the expelled gas measured?
It's measured with a spirometer, which is a device used to measure how effectively and how quickly the lungs can be emptied.
And then, does it show the expelled volume?
Yes, and it produces a volume time curve called a spirogram. I will review the three main values that are assessed with COPD patients. FVC stands for forced vital capacity, and it is the maximum volume of air that can be exhaled during a forced maneuver. FEV1 stands for forced expired volume in 1 second. It is the volume expired in the first second of maximal expiration after a maximal inspiration. This is a measure of how quickly the lungs can be emptied. The FEV1 to FVC is the FEV1 expressed as a proportion of the FVC. It gives a clinically useful index of airflow limitation.
This is so confusing. I don't understand how it relates to gold.
The ratio FEV1 to FVC is between 0.7 and 0.8 in normal adults. Values less than 0.7 indicate airflow limitation and thus COPD. Mrs. Tubbs' most recent post-bronchodilator FEV1 to FVC is 65%. By using evidence-based GOLD categories, we can classify the severity of Mrs. Tubbs' airflow limitation. I'm going to draw table 3 out of the Pocket Guide, and we're going to relate it to Mrs. Tubbs' results. So there's GOLD 1, 2, 3, and 4. This is mild, moderate, severe, and very severe. If you were in category 1, you would have an FEV greater than or equal to 80% predicted. If you're in category 2, then you have an FEV1 that is greater than 50%, but less than 80. If if you're in category 3, you have an FEV1 above or equal to 30%, but less than 50%. And then if you're in category 4, which is the worst, you have an FEV1 less than 30% of your predicted. Mrs. Tubbs, who we talked about this morning, fits into gold category 2 right here.
So gold classification is a simple way to categorize how severe the COPD is, how the patient's airflow is being limited based on post-bronchodilator FEV1 values. Gold 1 indicates the most ability to blow the air out, and gold 4 is the worst classification. And it means the patient has the least ability to blow the air out.
Exactly.
So does every adult have the same predicted FEV1?
No, FEV1 is influenced by age, gender, height, and race, and is best considered as a percentage of the predicted normal value. There's a vast literature on normal values. Those appropriate for local populations should be used. Spirometry is needed to make a clinical diagnosis of COPD. Together with the presence of symptoms, spirometry helps gauge COPD severity and can be a guide to specific treatment. A normal value for spirometry effectively excludes the diagnosis of clinically relevant COPD. The lower the percentage predicted FEV1, the worse the subsequent prognosis. Now I'm going to draw 2 more graphs from the pocketbook. So this is 1 and this is 2. Okay, so this one is going to be a normal spirogram, and this one is going to be someone with COPD. So if you have a normal spirogram, it looks like this. And if you have COPD, it looks more like this. And this is, on this axis, that's the volume that you exhale, and this is the amount of time that goes by. So people with obstructive lung disease, it takes them a lot longer to get the same amount of air out. They can't force it out all at once. So when you compare the 2 graphs, it takes a person with COPD 5 seconds to get 3 liters out. But for a normal person, they can get 5 liters out in 5 seconds. People with obstructive diseases have decreased flows and trouble getting the air out. FEV1 declines over time and usually faster in COPD than in healthy subjects. Spirometry can be used to monitor disease progression, but to be reliable, the intervals between measurements must be at least 12 months.
So how do you perform spirometry?
Good question. Mrs. Tubbs is eating right now, so I have time to show you how to do a real demonstration.
Is it going to hurt?
Not at all. I'll talk you through it, and then we can look at your results.